Advanced Trauma Management Q&A. Continuous rapid-fire assessment loop.
A trauma patient arrives following a stab wound to the left chest with a systolic blood pressure of 85 millimeters of mercury, which improves slightly with IV fluid resuscitation. The chest X-ray demonstrates clear lung fields. What is the most appropriate next step? A. CT scan of the chest, B. Pelvic X-ray, C. Fast examination, or D. Tube thoracostomy of the left chest?
The correct answer here is C, the FAST exam. During the circulation section of your primary survey, you've absolutely got to identify 4 life-threatening injuries promptly: massive hemothorax, cardiac tamponade, massive hemoperitoneum, and mechanically unstable pelvic fractures with bleeding. Now, in this specific patient, a hemothorax is highly unlikely given the normal chest X-ray. Because of that, you should be highly suspicious of a hemoperitoneum or cardiac tamponade. The best way to nail down this diagnosis: a bedside ultrasound of the pericardium and abdomen, which are key components of the FAST examination. So, your exam pearl to remember: clear lungs plus shock and penetrating chest trauma equals suspect tamponade or hemoperitoneum.
In which of the following patients is an emergency department thoracotomy contraindicated? A. An MVA victim with cardiac tamponade on ultrasound and an SPP decreasing to 50 millimeters of mercury. B. An MVA victim who is asystolic during transport with 5 minutes of CPR. C. A patient with a chest stab wound and an SPP decreasing to 50. Or D. A patient with a chest stab wound who is asystolic during transport with 20 minutes of CPR. The answer is D. What's absolutely crucial to grasp here is the definitive timing threshold. We know resuscitative thoracotomy is associated with the highest survival rate after an isolated penetrating cardiac injury. However, if a patient has undergone more than 15 to 20 minutes of CPR after a penetrating mechanism without any response or signs of life whatsoever, the procedure is frankly futile and completely contraindicated. It's true that outcomes are universally poor for blunt trauma too, but CPR under 5 to 10 minutes is a bit of a relative gray area. That's compared to the absolute contraindication of 20 minutes of CPR in a penetrating mechanism. Your exam pearl: RT is absolutely contraindicated after 20 minutes of CPR in penetrating trauma. After an automobile accident, a 30-year-old woman has a posterior pelvic fracture. Her hypotension and tachycardia respond only marginally to volume. Once it's evident that her major problem is free intraperitoneal bleeding and a pelvic hematoma, the appropriate management is A. Anti-shock trousers, B. Arterial embolization, C. Celiotomy and internal iliac ligation, D. Celiotomy and pelvic packing, or E. External fixation. The correct answer is D. This really highlights the hierarchy of operative control. In an unstable trauma patient with free intra-abdominal hemorrhage, an emergent celiotomy or laparotomy is totally mandatory. If that retroperitoneal pelvic hematoma has actually ruptured right into the peritoneal cavity causing active hemorrhage, packing the pelvis tightly with laparotomy pads offers the best hope of structural control. Internal iliac artery ligation is rarely effective and has largely been abandoned, and an external fixation just doesn't stop free intraperitoneal bleeding. The exam pearl: an unstable pelvic fracture with free intraperitoneal bleeding requires an emergent celiotomy with pelvic packing.
We have an 18-year-old man post-MVA, GCS 7, pulse 140, BP is 60/0. He has rapid breathing, but clear lungs, distended abdomen with no peristalsis, plus closed arm and leg fractures. After giving 2 liters of lactated ringers, his pulse is 130 and his BP is 70/0. What's the next immediate step? A. C-spine X-rays. B. Head and abdominal CT. C. Supine and lateral abdominal X-rays. D. Arch aortogram. Or E. Intubate and proceed to the OR to explore the abdomen.
The correct move here is E. This case builds right up to a critical decision point. Yes, the severe head injury absolutely requires an airway, but the head injury itself doesn't explain that profound hypotension. The distended abdomen points directly to a massive, uncontrolled abdominal hemorrhage. Because he's hemodynamically unstable, he literally cannot leave the resuscitation bay for CT scans or diagnostic X-rays. He must be intubated and taken immediately to the OR for an emergency exploratory laparotomy to stop the bleeding. The exam pearl: non-responsive shock and a distended abdomen means you go straight to the OR for an exploratory laparotomy.
After a gunshot wound to the right upper quadrant, the patient has no signs of peritonitis. Vital signs are stable, and the CT shows a grade 3 liver injury. What's the next step? A. Exploratory laparotomy with hepatic control. B. Admission to the SICU with serial CBC. C. admission to the SICU with repeat CT in 24 hours, or D, hepatic angiography?
The correct answer is B. So the really crucial point we're dealing with here is knowing when not to operate. Non-operative management of solid organ injuries, including the liver, is the standard of care for patients who remain hemodynamically stable and have zero signs of peritonitis or other indications for immediate surgery. Patients with a grade 3 injury should be closely monitored in the surgical ICU with serial abdominal exams and serial hemoglobin checks. Keep in mind, angiography is reserved for active contrast extravasation or specific transfusion triggers. Example: a hemodynamically stable grade 3 liver injury without peritonitis mandates non-operative management in the SICU.
Which is correct regarding traumatic spleen injury? A, a white blood cell count of 20K and platelets at 300K on post-op day 7 is benign. B, delayed rebleeding typically occurs within 48 hours. C, common complications include a subdiaphragmatic abscess, pancreatic tail injury, and gastric perforation. Or D, vaccines are optimally given pre-op or immediately post-op.
The answer is C. Anatomy is completely the key to understanding this one. Common surgical complications that are unique to a splenectomy stem directly from anatomic proximity. This includes iatrogenic injury to the tail of the pancreas, which can cause a fistula or ascites, injury to the greater curvature of the stomach during short gastric vessel ligation, and subphrenic abscesses. A persistent leukocytosis greater than 15,000 beyond postoperative day 5 is actually associated with sepsis, so it's definitely not a benign finding. Furthermore, post-splenectomy immunizations should ideally be delayed until at least 14 days post-injury to ensure an optimal host antibody response. Your exam pearl: splenectomy surgical complications stem directly from anatomic proximity to the pancreas and stomach.
At what pressure is operative decompression of an extremity compartment mandatory? A, 15 millimeters of mercury, B, 25 millimeters of mercury, C, 35 millimeters of mercury, or D, 45 millimeters of mercury?
We're looking for 45 millimeters of mercury, so the correct answer is D. Notice just how exact these physical pressure boundaries are. While a normal compartment pressure is near zero, compartment pressures exceeding 45 millimeters of mercury indicate a critical loss of perfusion pressure. That dictates an urgent operative fasciotomy to prevent permanent neuromuscular necrosis. Pressures sitting right between 30 and 45 represent a borderline zone that requires serial evaluation and really close observation. Example: compartment pressure greater than 45 millimeters of mercury mandates immediate fasciotomy.
Primary repair of the trachea should be carried out with A, wire suture, B, absorbable monofilament suture, C, non-absorbable monofilament suture, or D, absorbable braided suture.
The right choice is B. The absolutely crucial point when it comes to the airway lumen is managing tissue reactivity. Tracheobronchial structural lacerations or transactions should be directly closed using a running 3-0 absorbable monofilament suture. Braided sutures or non-absorbable materials are completely avoided in the airway lumen to prevent long-term foreign body reactions, granuloma formation, or even chronic ulceration and infection. Example: tracheal repair requires an absorbable monofilament to prevent granulomas. A patient with spontaneous eye opening who is confused and localizes pain has a Glasgow Coma score, or GCS, of A, 9, B, 11, C, 13, or D, 15. The correct answer is C. Let's just methodically assemble the score here. The components tally up pretty cleanly. Spontaneous eye opening gives us 4 points. A confused verbal response equals another 4 points. Localizing painful stimuli gives us 5 points. So the total score is 4 plus 4 plus 5 equaling 13, which actually falls right into the mild traumatic brain injury category. The exam pearl is just a simple breakdown. GCS total equals eyes out of 4, plus verbal out of 5, plus motor out of 6.
Regarding neck injuries, which statement is true? A, less than 15% of penetrating injuries require exploration, as they are mostly managed conservatively. B, zone I is above the mandible. C, all patients should receive a CTA. Or D, patients with dysphagia, hoarseness, or a hematoma should undergo exploration.
It's A. It's really fascinating to see how modern protocols have evolved for this. Modern management of penetrating neck injury utilizes selective non-operative management. Today, less than 15% of all these injuries actually require a formal surgical exploration. For a quick recap on the zones, Zone 1 is inferior to the clavicles. Zone 2 is between the outlet and the mandibular angle, and Zone 3 is above the angle. Also, soft signs like dysphagia, hoarseness, or a hematoma prompt diagnostic imaging like a CTA first in a stable patient, rather than rushing to an immediate blind exploration. Example:
Penetrating neck trauma in stable patients is managed selectively. Routine blind exploration is completely obsolete.
The most appropriate treatment for a duodenal hematoma that occurs from blunt trauma is A. Exploratory laparotomy and bypass of the duodenum, B. Exploratory laparotomy and evacuation of the hematoma, C. Exploratory laparotomy to rule out associated injuries, or D. Observation.
The right answer is D, observation. This is actually a fantastic example of trusting the body's natural resolution process. You see, the vast majority of intramural duodenal hematomas resulting from blunt trauma just resolve spontaneously. Initial management is highly conservative. We're talking observation, nasogastric decompression, and parenteral nutritional support. Surgical intervention is strictly warranted only if you suspect a full-thickness bowel perforation or if that hematoma completely fails to show any clinical or radiographic signs of clearance after 2 to 3 weeks of therapy. Remember this exam pearl. A blunt duodenal hematoma is initially managed conservatively with observation and NG decompression.